All right, in this video, we're going to go through a new pathway that is relevant to a lot of different types of cancer that we haven't really looked at before, and combine the sort of concept of the pathway with a new treatment and an interesting genetic screening therapy to identify patients that are most at risk and figure out which treatments will help them the most. So EGFR is epidermal growth factor, and the R is for the receptor. So EGF is a signal that's released from all sorts of different cells. It got its name epidermal because it is released from the epidermis, but many other cell types too. And so EGF, if there are many other cells in this culture, they're releasing EGF, which is a ligand, right? Effectively like a hormone that will drift to surrounding cells and bind the receptors. And it's a way for cells to signal to each other what conditions are like, whether we need new cells to grow. And that's basically a readout of cell density. So in a healthy person's skin, for example, you need a certain number of cells in the epidermis to make the layer of skin complete. And if the number of cells gets too low, they'll start secreting EGF. EGF binds receptors on surrounding cells, and that activates a handful of different pathways that pretty much all funnel into the nucleus of the cell and turn on genes involved in cell division or proliferation, angiogenesis, which means like the growth of new blood vessels, and generally decrease or inhibit apoptosis. And that makes sense because if a tissue is short on the number of cells that it has, we want to make more, right? Get them to start dividing. That's proliferation. We want to be a bit more aggressive on saving the cells that already exist. That's the anti-apoptosis. And if you make a large amount of tissue, it's going to need new blood vessels, right? Capillaries that deliver oxygen to it. And so angiogenesis, because those capillaries have to be told that they need to grow by branching off of other capillaries, right? Now, as cancer always tends to do, it manipulates existing pathways. It's not creating brand new ones. And so in cancer tissue, a handful of things can happen. You can have increased expression of EGFR, the receptor on the cancer cell. The cancer cells can also start secreting EGF themselves to stimulate other tumor cells to grow faster, essentially encouraging or egging each other on and increasing growth of the tumor. So if we're going to block that pathway, you can block a handful of different points, but it's going to be most effective if you target the actual receptor itself, because this, I know they're showing it many times, but this purple receptor is the same thing. It's just different cell types, different circumstances. There are different pathways. And so if we target one of these downstream components, you're only really targeting a fraction of what EGF does. Whereas if you target the actual receptor itself, right, like with these antibody therapies that bind the receptor, and then you block EGF from binding in the first place, you can effectively shut down all of these pathways all at the same time. Right. So in tumor growth, this picture is a little bit busy and a little wild, but the idea is your EGF is fueling cancer growth because these cells already have EGF receptor to begin with, right? And it's all about overexpression and mutations. So some cells just straight up make more EGF receptor, some cells secrete more EGF, but there are also a lot of mutations that go along with it that can make these components sort of falsely activated. So you could imagine a mutation in the receptor itself, right, that made so the receptor was on even when EGF wasn't present. We would call that a constitutively active gene. Those tend to be oncogenes in that if you only get one mutation in them, that's enough to encourage cancer growth because it's hyperactive. The other copy of that gene isn't going to be able to shut it off or check its activity. You can also imagine activation of any of the downstream proteins. All of these are very, very common, proteins that are mutated in cancer. And if you're going to figure out what treatment will work for a particular patient, you ideally would want to know, okay, exactly which components of the pathway are mutated, right? Because if your mutation is in MEK or ERK, it won't really do a whole lot of good to target the receptor because the problem is happening downstream of the receptor. And if you hit your drug upstream, it's not really going to do any good. All right. So the specific type of cancer we're going to look at here is lung cancer. And the point of this is EGR or EGFR is not the only mutation that fuels lung cancer by a long shot. It's a very common one. All right, so EGFR is one. These other targets, HER2 and c-MET, are other receptors that are often implicated in lung cancer. And what's difficult sometimes is they can all feed into common pathways. So pathways crosstalk, they're not straight up linear. And so again, we want to know which set of mutations are involved. Because if the patient does not have overactivation of the EGF pathway, probably doesn't make a whole lot of sense to make that a target. And you can easily figure that out by taking a biopsy of the tumor and sequencing to find out which particular genes have the mutation so you know how to custom target your drug. All right. Okay, so the pathway side of it is a big deal. And this is a large part of what determines are those tumors going to metastasize and how does that fuel spread throughout the rest of the body? Okay, so specifically, the small cell lung cancer transformation is exactly what it sounds like. If the cells become smaller, they lose these cadherin proteins, which are a part of what binds cells together. This encourages metastasis and transformation, makes it easier for those cells to break away. Right? They're trying to show you cells floating out of the tumor mass. Right? They're going to break away. The smaller they are, the easier they can enter the bloodstream. And that's when you're more likely to get invasive cancers that spread to other organs because they enter the blood, travel to distant sites, leave the blood again, and then take up residence in some other organ. Right. Okay, so this concept, I took this from a review. I'm going to go through two papers. The first is a review talking about sequencing therapy, very specifically for, say, defined subgroups of non-small cell lung cancer. So we're dividing cancers into further and further groups, and this is, I think, maybe the most frustrating thing that I've heard from cancer researchers is that everyone treats cancer as though it's one thing, when in reality, every type of cancer is different, every subtype of cancer is different, and every individual patient to some degree is different because you're almost never going to find two people that have the exact same set of mutations, and you won't even find cancer cells within one tumor that have all the same mutations. And so there's an enormous amount of complexity. The idea here is, even if they're not identical, if we can put some sort of genetic identifier on different cancers and cancer cells within a patient, then we can do a much better job of determining which treatments are going to be the most helpful. So the goal is we want to find these driver mutations, which means the mutations that are driving the growth of the cancer. And remember, these are either going to be oncogenes that are cell or proteins that encourage cell growth that have been hyperactivated, or they're going to be tumor suppressor genes that have been inhibited. In general, our targets are the oncogenes because we want to focus on turning off the hyperaggressive pathway. There's realistically not very many good ways to turn on a failed tumor suppressor pathway. Right. I added this table, and this isn't even the entire thing. It went on to another page, and I clipped a reasonable portion of it. This is showing all of the different either approved, right? Some of these have an approval status in the U.S. or the EU, and then others that are sort of just in research phases or in trials that haven't been approved yet. The number of possible treatments for a physician to select from is incredible, and I think the thing to take away from this is if all you know is that a patient has a certain type of lung cancer because you've seen it on an image from a scan and maybe under a microscope from a pathologist, there is absolutely no way that that information can tell you which out of these 20 different options is the best choice for that patient. Because the difference between like all of these targets, all of these drugs, target EGFR mutations. Which one? EGFR is a big complex protein, a lot of amino acids. There's absolutely no reason to think that one drug that works against a certain mutation is also going to be equally effective or even effective at all against another mutation. And so the difficult part is gathering this data can be very, very tedious and time consuming because there's no way to predict, at least currently, just by looking at the shape of these molecules, you have no way of knowing which particular mutations they're going to work best against until you just try them, right? And so we run into that same problem that we've always had. There are a limited number of people with cancer that are willing to participate in a trial, right? And every drug requires a fairly large number of people. And if you're going to compare different subtypes of patients based on their genetic status within those groups, then you need even more individuals because now you're not just comparing, control versus treatment. You're comparing different genotypes, people with different genetic mutations in their tumor against other types of mutations. And so the sample size just has to keep getting larger and larger. Right. Okay, so what they found. This is really even an oversimplification. So they called this molecular cohorts of lung cancer. So for example, EGFR sensitizing, meaning mutations that make cells hypersensitive to that EGFR pathway so that they're stimulated more readily to go through cell division. But what I want to point out is even within this category, there are probably thousands of different mutations that can cause EGFR sensitization. Now, some are more common, some are probably incredibly rare and don't get a whole lot of attention paid to them. But this is just very high level category, right? And so all of these different considerations, is it EGFR sensitive? What specific mutations in EGFR that cause something other than sensitivity are present? All of these PTEN and CDK10-2A and BRAF and NF1, different proteins with different functions. And every one of them is going to have a slightly different effect on the tumor growth and probably respond best to a slightly different category of treatment. Okay. All right. The next part of this is to consider mutations arise at different times. So most patients that have cancer, especially aggressive forms of cancer, are likely to go through multiple rounds of treatment with multiple drugs in addition to surgery and radiation and everything else. And this concept of acquired resistance, effectively what this means is when a patient first gets diagnosed with cancer, they have a certain set of mutations that are present in those cancer cells, and we're going to use whatever therapy that particular oncologist decides is the most appropriate. And the acquired resistance part just means that the mutations aren't going to stop accumulating, right? The mutations keep building, and the mutations are random. But the catch is we used a particular drug, and that drug is hopefully going to kill some, probably not all, but we hope at least a majority of our cancer cells. But by definition, the cancer cells that survive are the ones that didn't get killed by the drug, right? And so acquired resistance, meaning the mutations that are found in the tumor occur by chance, but they don't survive by chance, right? Because they survive based on how well they avoid the mechanism of our drug, right? And so what they're trying to point out is you can have mutations that change the target structurally. The target meaning the receptor, like this would be our EGFR in our example. You can have mutations that lead to activation of the pathway from a different mechanism, so that even if our drug does inhibit the receptor, it will effectively find a workaround to be activated another way. Target amplification, meaning mutations in a gene that simply increase the number of receptors so that the drug is less effective because there are just too many of the targets there to inactivate all of them. Downstream pathway activation, meaning the downstream proteins after the receptor are the ones that have the mutation that make them hyperactive. And I mentioned this earlier. This is the case where inhibit this receptor all you want. The mutation is in RAS or BRAF or MEK, right? And they're going to turn on the pathway whether the EGFR is stimulated or not, right? Same concept, alternative activation, meaning can you get to the same result a different way, right? This is a pathway that has a similar end result, but takes a different route. And then, alternative pathway activation is effectively merging these two together, right? A hyperactive mutation in an alternative pathway that somehow loops back around to our original pathway. And so what I was hoping to communicate with this is not linear. It's not even simply just minimally branched. It's a complex spider web of interactions between many, many more proteins than are even being shown here, right? And so we need an arsenal of many different types of therapy, and we need sequencing to find out where the problem is, so that oncologists know, right, what target they're even going after. Okay, so a specific example of this. That review, I think, did a good job of covering the conceptual aspects of this in theory. This is a phase 1 trial for an anti-EGFR antibody, right? We give it a name. And they are being so precise. This is targeting EGFR mutations, but very, very specifically an insertion in exon 20. And if you don't remember from the earlier genetics information, an exon is just a part of a gene that codes for a protein. Introns are the other type of DNA in a gene, and they don't code for protein. And so we know that EGFR has at least 20 exons. You could imagine mutations in any of them. And so we are getting to the point of being very precise in saying patients with this exact mutation, they have reason to believe, probably from cell biology experiments, to think that this antibody specifically will target this cancer fairly well, right? And so what they effectively did is they recruit patients that have this non-small cell lung cancer, which is not incredibly common. And then they go about screening them for any patients that have that exon 20 deletion, right? And in total, they found 121 patients that were enrolled and received this antibody in combination with another drug, right? So 2 different drugs. Here's the antibody. This is a small molecule therapy that's already shown to have some benefit, and we're testing it to see if it works better than the small molecule drug alone. Right. So what we get is a very interesting set of data here where we're seeing percent change from baseline as far as reduction in tumor volume. That's the response that we want. And these categories are even further subdividing those patients based on the very, very precise effect that the mutation has on the EGFR, on our target protein. And so these numbers, 762E and 763A, these are individual amino acids, right? 762 is the amino acid number in the protein, and E is the single letter abbreviation for glutamic acid, which is one particular amino acid, right? And so now you get a visual, right, and see that, certain mutations tend to do slightly better than others, although there's not an incredibly clear pattern, right? These patients tended to do incredibly well. Obviously, like we always see, these unlucky few actually had their tumors continue growing. But overall, the drug was relatively successful, right? And you can now crunch statistics on which of these very precise mutations was most likely to give the best results in slowing down tumor growth. All right. And lastly, this figure is, I thought this was really cool. It's terrifying in a way, but it's interesting. All of these designators on the x-axis are different genes. EGFR, TP53, PIK3CA, each one is a different gene, different protein. And what they're saying is we initially screened these people for whether they had a mutation in EGFR, which is why everyone up here has an EGFR mutation of one type or another. And then they're going to say, okay, what other types of mutations do these people have, right? Do they have a mutation in P53 or NF1 or FOXA1? And we're trying to line them up and see, is there any trend that we can find where patients that did incredibly well had a certain set of mutations but not another, right? And this is the level of combinatorics that we're getting to in cancer therapy is, again, it's not just one gene, it's not even two. If you start scanning down here, most of these people have multiple mutations, and they almost certainly have mutations in other genes that just weren't included in this list. Right? And what you can do now is feed this information into a statistics program, probably an artificial intelligence program at this point, and ask it, okay, which of these are most likely to be predictive? The problem is, in this data set, probably only these top 2 or 3 hits that are most commonly found are going to have enough of a sample size to give you that info. Whereas these guys down here, where only a small handful of people had it, that's not enough individuals to do statistics on, which was my point earlier, that the more of these genes you want to look at, the bigger the sample size is going to have to be, because the rare mutations simply aren't going to give you the sample size you need for comparison. All right. Okay, like always, hope it was interesting, and talk to you about it soon.